Welcome, everybody. It's my privilege to introduce Jennifer McAdams, who's the Clinical Director of Eating Disorder Services, Eating Recovery Center and Pathlight Mood and Anxiety Center in Chicago, Illinois. Is that correct? And Leah Young is the Critical Manager of the Addiction Recovery Track and Eating Recovery Center and Pathlight Mood and Anxiety Center. So, welcome.
Thank you. All right, we'll come over here. And then I think you can even be a little bit closer. We can both be on camera. Yay. Okay. So this is the first time doing this setup, so bear with us. Thank you all for having us at this conference. Super excited to be speaking. You should know off this presentation, we probably could go on for 3 days. So we're gonna try to do that in an hour and 15 minutes. So we might move a little fast. We are okay with questions throughout the presentation. That is not a problem. And you can also always go to the Eating Recovery Center website or Pathlight Mood and Anxiety Center. We have the same parent company. There's tons of resources on many of the items we're speaking about today there as well. So today we're going to be talking about eating disorders and substance abuse population because there's a lot of overlap between the two diagnoses. First, conflict of interest.
The usual conflict of interest statements. I'm sure you've seen plenty of these even in the last 2 days. There are none. We have no conflicts of interest. I'm not going to read that word for you. And we can probably move on.
I hope that really excited you all. Yeah. All right. Objectives. Once again, we're going to talk about the similarities and differences between eating disorders and substance use, describe treatment approaches, and I hope everyone can take 1 or 2 things away for these diagnoses, and outline the treatment team throughout different levels of care, which is also helpful to know if someone's really struggling to the point that outpatient isn't enough, and also empowering caregivers on how to support patients. We'll touch briefly on that through a theory called emotional focused family therapy.
So I want to start off by talking about some of these co-occurring statistics. And this is something that I share with our patients because a lot of we're not primary substance use. And so our patients come in for mood and anxiety or for eating disorders, and then they're told that they have to meet with me, and they're not real happy about it because they say, I don't have a problem with substances. And so one of these things that these statistics that I share with them is that about half of people with eating disorders is already abusing or will likely begin abusing substances at some point in their lives. And usually getting them to think a little bit about why that might be, and it starts to connect the dots for them, and many of them become very willing to take a look, at least just explore their use of substances. And you know that is 5 times, 50% is 5 times the average rate. We usually look at about 9 to 10% of the population struggling with addictions. On the flip side of that coin, those folks that we work with who already have a substance use disorder are 10 times more likely to also have an eating disorder. And I come from primary substance use. That's my background. And I'll tell you, once I started working in eating disorders, I started to recognize how many of my patients I've been working with who had these eating disorder behaviors that I didn't recognize as being eating disorder behaviors. And I'll talk about that a little bit later. About 28 million people of all genders and ages do struggle with an eating disorder within the United States. That number is probably on the low side because we have a lot of folks who are not diagnosed, they're not receiving treatment, not acknowledging that they have eating disorders, but that's our rough estimate at this point. And then we do see, this is one of our little anorexia nervosa and substance use disorder comorbidity do have a higher suicide rate and just mortality in general, mortality rate. So this is something I talk about our folks with anorexia in particular often will come to eating disorder treatment and told that you need to take care of your substance use issues before you can come to eating disorder treatment. And then they come to a substance use and they're told that they need to take care of their eating disorders, and those folks fall through the cracks. And I imagine feeling hopeless and kind of left out really does contribute to this.
All right, this is what I call my cliff notes of eating disorder diagnoses because there are many of them. If you want a more thorough guide to information, please look to the DSM-5, which is the Diagnostic manual for mental health. Anorexia nervosa. Well, before I start, first off, one thing with eating disorders to know is we're getting better, and it traditionally has been known as like the anorexia, right? The person who really struggles to get enough calories in each day and has a very certain look. When in reality, eating disorders impact all body types and body sizes, and actually pretty much every one of these diagnoses can impact all body sizes. The large majority of eating disorders you actually cannot tell just by looking at a person, and that's a really important education piece I want everyone to just really learn and grasp onto. That even includes the anorexia nervosa, which is that self-starvation, excessive weight loss in many cases, and it has two different diagnostic categories: a restrictive and a binge purge. And ultimately, at the end of the day, their intake is much lower than their extake, what they are expending in energy. The bulimia nervosa is a cycle of binging and compensatory behaviors. You almost often hear about binging purging cycles, but the compensatory behaviors also can be over-exercising. There can be diuretic abuse. There can be laxative abuse, many other pieces, and that getting out that energy or whatever they consumed in whatever way almost always happens right after the binge with the bulimia. And the OSFED, otherwise specified eating disorder, is if someone has a lot of the diagnostic criteria of one of the main eating disorders, yet it does not quite fit anyone particularly, that's where you get the OSFED. Avoidant restrictive eating disorders is ARFID is something that is a little bit newer. If you have ever worked with or met someone who maybe is a really picky eater and only eats like 10, 15 foods, oftentimes that's been like that since birth. That's an ARFID diagnosis. Oftentimes they're really struggling to get enough variety in their diet to be able to thrive. And I think my bulimia my binge eating got kicked off.
I noticed.
Sorry, someone copied over this presentation for us. Lastly, binge eating disorder, which is binge eating cycles that does not have that compensatory behaviors, and they're taking excessive amount of calories in short periods of time.
Is the ARFID ever also associated with the issues around, and tell me if I'm way off, the food touching?
Oh, so like food touching on plate and such?
Yeah.
Sometimes can be connected with that as well. A lot of it can be for the ARFID, it can be also texture-based. A lot of occupational therapy happens with it. I've seen it a decent amount, also even with people on the spectrum as well. And so like it's all, and I think one of my biggest pieces with that is there is treatment and support with that to help get that variety of nutrients our bodies need in us. Good question, thank you. Behaviors that may be indicated for an eating disorder. We're gonna go through these really quickly, but basically what I say is anything done too little or too excess can somewhat be an eating disorder behavior, and it's actually kind of funny. Sometimes when we sit and really think about it, what can be conceptualized. Now, for the majority of things we're gonna list, some people probably have done these at some point or another. And so if there's one or two things where they're ebbing and flowing and not impacting life or the health, it's not the end of the world. I feel like America generally just has kind of, disordered eating. That's how we are as a society. It's when you're really seeing multiple things or these things being done in such extreme or so little, it's especially impacting life, friends, family, work, a lot of avoidance. So some of them are consistently leaving the table within 10 minutes of eating a meal, especially if they're going to the bathroom or immediately having to go walk after, like a quick walk or exercise. Stirring or playing with food rather than eating. Someone who struggles with food can be a master at moving things around their plate. And if you really observe, there's not much going in their mouth, but it gives the perception that they have completed the meal. Skipping a bunch of meals and then overeating at another meal. We especially see this both with the anorexia and bulimia. People will tend to eat more when they're around people versus when they're alone. And also the binge eating tends to get in a vicious cycle sometimes of restricting throughout the day and then binging at night, especially when they're alone.
Isn't that normal?
This is what I'm saying. Do you see what I'm saying? No, I know you're kidding, but that's why there's sometimes like I read through them and I'm like, oh no.
Yeah.
It might be one of them. So consistently tired or fatigued. But once again, like you're looking at the overall pattern or if there's a change in the person, right? Consistently setting and communicating goals around getting physically healthy, always going through the newest trend and adding trend after trend after trend after trend. Exercising despite physical injuries, exercising more than an hour and a half a day, more than 4 to 5 days a week. Once again, exercise is good for our mental health, right? But if you take the exercise away, and there's a lot of anxiety or struggle, that's probably your sign if you're not able to take a day off for the person you know. Restricting foods or food groups, especially if it starts building on each other. We see this especially with adolescents. They have a health class and they're, I'm going to go vegetarian. And parents like, cool, great. And then it's like, well, now I don't want gluten. And now I'm not going to have any dairy. And if it starts building. And once again, with that, it's, what are the trends? What are like the extremes, right? Because in diet culture, it's not atypical to do that, but you are able to go back to eating. And we also do a lot with ERC on like working on diet culture and trying to get that to go away, hopefully. Talking about particular foods as good or bad, and especially if the judge bad foods, like they will never eat. There's a hard, fast rule around that because it's important to eat all foods in moderation. Gaining weight in treatment, inordinate amounts of conversation about food, weight, the body, and calorie intakes. That's all they talk about. That's all they obsess about. Really rigid eating patterns. Once again, before meals, during or after, there's set things that have to happen. If that does not happen, the level of anxiety or response might be a little greater than the average person. Social, like behaviors that may be indicative of an eating disorder continued, and this is a little bit some of these are a little bit, I forgot the word I was looking for there, include
physical, biophysical, yeah,
there you go. Socially withdrawing, increased anxiety, as I mentioned, mood swings. You might see someone, especially in the adolescence, that usually is kind of easygoing, and suddenly they're starting to like snap. So you're going to see a lot of anger a lot of times come out. Difficulties concentrating. As we mentioned, some may or may not have weight fluctuations. That's not always an indicator, but especially if you're seeing it go down or start going up, that's atypical, especially in children and adolescents from the growth patterns. Dizziness, cold, sleep issues. For those who do the purging, calluses on the back of their hands. Also, they tend to start getting a lot of cavities. And a lot of dentists actually will catch this first with bulimia because the acid erodes the teeth. So if you know someone that's not typical for having cavities, suddenly has a bunch, or they're noticing the enamel wearing down, that might be a sign there. Hoarding food, change in exercise patterns, excessive gum chewing, excessive use of caffeine or sparkling water. I've never been guilty of that last one, especially today.
All right. So, our studies suggest, and this is true for substance use disorders as well, is we want to catch these things as soon as possible. And so they're talking here about sub-threshold levels of eating disorder. So starting to notice disordered eating before it becomes a full-blown eating disorder, and that's true for substance as well. And then, this facilitates earlier intervention, right? And one of the things that we do at ERC and Pathlight that I really think is incredibly important is I try to educate all of the patients, even if they have not been kind of earmarked for substance use programming, because even people who use somewhat moderately or not problematically are at risk, right? Because we all have a brain, therefore we're all at risk. So we really want to plant the seeds early. That's really what we're trying to do there. So really understanding, and I mentioned this early on, when I was in primary substance use, how many eating disorders were hiding behind substance use disorders. I don't know how many times I've had people stop drinking alcohol only to start consuming massive amounts of sugar. And that seems like that's what we expect them to do. I mean, you think about AA meetings and donuts and people with candy in their pockets and that kind of thing. But really noticing that it may just be a reaction to stopping drinking, but it might also be disordered eating. We do want to take a look at that. I think of how many people have stopped using substances only to start running multiple marathons in a year. And then that gets co-signed by society, like, wow, that's great. Boy, I wish I had the willpower to work out that way or run 6 marathons or whatever it might be. But really, it's not how it's replacing one addiction with another, as many of us have learned. So really noticing that, but also kind of the flip side of that, where substance abuse can mask the eating disorder and be utilized as part of the eating disorder. I think of, we've had several patients who come in having gotten to the point where the only way they can eat a meal is if they've had something to drink. So they're getting intoxicated in order to reduce the anxiety around food so that they can eat. And then it becomes, well, I can only eat when I'm drunk, which is problematic on both fronts. I see people using cannabis, obviously, to stimulate appetite. We see people using stimulants, both illicit and prescribed, in order to suppress appetite. So we really want to pay attention. I can't tell you how many patients come in with a diagnosis of ADHD and they're livid when we take them off of their stimulants. Firstly, because we don't necessarily know that they actually have ADHD. But we need to take a look at some of those things. So really what we're looking at is eating disorder behaviors, much like substance use behaviors. We're just looking for numbing mechanisms. We just want to feel better. They're just trying to regulate their brains and not deal with the intense amount of stress or the emotions that feel overwhelming or the anger that they're trying to suppress or whatever it might be. Very similar to folks who use substances. So a quick, those of you who do work in substances are probably familiar with the CAGE questionnaire. The SCOFF is a helpful kind of quick questionnaire to determine if somebody that I'm working with in substance use treatment may be engaging in some eating disorder behaviors. So you can, we did the acronym here, just like we did with CAGE, but do you feel sick? Do you make yourself sick or feel uncomfortably full after eating? Now, okay. Let me just say, at Thanksgiving, that's kind of my goal, but that's that one time of year. And, and really what we're looking for is we're looking for more of a pattern. We're looking, for that regularity. Do we worry that we've lost control over how much we eat or our food intake? Have we lost more than 1 stone? You can see this was not developed in the United States. So that's about 14 pounds in a 3-month period. Do you believe yourself to be fat when others say you're too thin? And would you say that food dominates your life? And I would say food and everything associated with it, right? So this can, somebody answers yes to a few of these. This might set off some alarm bells that I need to get this person assessed by somebody who is a professional in eating disorders. It doesn't tell us that there is definitely a diagnosis there, but it can really be helpful. Again, much like the CAGE can be helpful. Okay, some things about what to ask and what not to say. I'll have Jennifer jump in a bit here.
All right, so things that are helpful to say. What do you think about your body? What kind of diets have you tried? What are some ways you've tried to lose weight? These are all if you're suspecting and working with someone who might have an eating disorder. Have you had worries about eating and your body impacting your daily life? How often do you make up to spend calories after eating in order to keep from gaining weight? How often do you feel out of control when you're eating? How often do you eat for reasons other than being physically hungry? Once again, do you see how those questions are trying to feel out? How often are things happening? What level of out of control? Because some of these things apply to all of us, and not every single day or numerous times per week. Don't say to people, you don't look like you have an eating disorder. It should be known that insurance companies are still catching up with that part. I could stand to lose some weight myself. You look good. It's actually funny that you look good and you look healthy are meant so well. Many of these things are, right? They come from a good place. And for someone with an eating disorder, even saying you look healthy, the eating disorder takes over in their brain and goes, you're eating too much, blah, 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 like you're looking good. And so we really encourage comments that are focused more on like how the person, the brain, the emotions, like those types of validations.
Honestly, something safe to say is, it's really good to see you.
Yep.
I mean, really, that's the safe, because usually that's what that translates to. I haven't seen you well, maybe you've been away to treatment. I just want to let you know how much you look healthier. Just saying it's good to see you is a really safe one.
Just eat healthier foods. You don't look fat, you are too skinny. these, once again, often come from a good place, and someone struggling with an eating disorder can really impact them.
Yeah.
All right, similarities.
So some of our similarities, and there we have pages and pages of these. So our eating disorders and substance use disorders both typically begin in adolescence or early adulthood. Certainly some people can look back in hindsight and say, I knew at 4 years old. When I look back at 4 years old, I was already comparing myself to other kids' bodies. They both include behaviors which really function to maintain the disorder, despite negative consequences. So there's, and we'll talk a little bit about that. So there's some denial and secrecy and shame, because eating disorders and substance use disorders cannot live in the light of day. They need to be kept secret from everyone that knows us in order to be able to continue to engage in them. Both have a high tendency for recurrence of use or recurrence of engagement and behavior, and are what happened here and to my brain, and alter the way we relate to other people, right? So certainly our interpersonal relationships are impacted by both substance use disorders and eating disorders. Again, if I value honesty and I find myself having to be deceitful in order to continue to use my substance or engage in my eating disorder, I'm going to have intense shame about that because I'm lying to my husband every day or my mother or whatever it might be. Both have high mortality rates and are life-threatening disorders. As we know, those of us who work in this field have seen it all too often. And both are long-term illnesses. So this is something that we have to pay attention to for the rest of our lives. It doesn't mean we have to be as vigilant when we're 5 years in or 10 or 20 years in, but we still have to have an awareness. Whenever cured, I'm all better, I can go back to old behaviors, right? And it'll be okay. And we know folks who've done that. Maybe some of us have done that. And then we learn the hard way, like, oh, darn it, this is something I have to keep paying attention to. Both are seen as moral issues. So those questions, again, they're meant well, but when we say things like, well, why don't you just eat? Just have a hamburger. That's all you have to do, as if they hadn't thought of that 14 times. It's the same thing as saying to somebody, well, you just have one beer, right? Well, you need to have 12. And, people are saying, oh, gosh, I hadn't thought of that. Thank you so much. But those questions, what they imply is there must be something wrong with you that you can't do this, or you must not love me enough if you can't do this. And those of us who've worked in this field know that it has nothing to do with that our people who struggle with substance use love their families and care about they have a passion for their careers, and yet find themselves continuing to use, and that's the insanity of it. So really being cautious about some of these more morally loaded questions. I mentioned the denial, secrecy, and shame, and then there's a lot of comorbidity, as we know, with anxiety, depressions, bipolar disorder, depression, bipolar disorder, etc. Yes, please.
Sorry, I've run into issues with, one, especially a client who got COVID prior to being vaccinated, had some of the long haul taste and smell.
Yes.
And it kind of brought back her eating disorder.
Yes.
So sadly, I'm doing telehealth with her, and she's arranging the camera, so I can only see from here up. And she's reporting that she's having trouble eating, and I suspect that she's very, very thin.
So the comment, in case you're not able to hear up there in virtual world, no, don't apologize. That's why I'm here. Is COVID knocking out that sense of taste for some folks, and it can really contribute to re-engagement in eating disorder behaviors. And we see this with other illnesses when our patients catch like a stomach bug, right? It's very legitimate. And it says to their eating disorder, like, well, here's a good excuse to not eat. And then we find, 3 days they're knocked out with this, and now they've spiraled backwards into their eating. Did you want to add to that?
Yeah, and I think even with the camera and the telehealth, I want to make sure I'm close enough to this, that gets tricky. There's a few things. A lot of the virtual platforms does allow hide self-view.
Yes.
So a lot of times what we do encourage the patients is click that hide self-view, and then I have with telehealth patients been like, okay, I need to see at least chest up or certain levels or when, and actually even another way kind of around it is because we're much up closer in camera to people, and that's like not how we function in life, is even normalizing like, hey, if we can hear each other, okay, why don't we both just take a step back? So it's going to feel a little bit more normalized in our session.
Good points,
Yeah.
yeah. We've talked about putting the post-it,
Yep.
Oh.
tell them that they can put the post-it up.
So they don't have to see
Yep.
themselves.
They don't have to see
Mhm.
themselves.
Yeah,
Although if you hide the selfie on yourself, make sure you remember the camera's on.
yeah.
I know, right?
Yes.
Yeah.
All right.
Yeah, thanks.
So, yeah.
I was just
So some more similarities. We have a lot of very similar behavioral symptoms. So difficulty managing tension, a lot of impulsivity, that compulsivity. And one of the things that I described that as, actually I had a patient last week describe it as it feels like there's a chain attached to my chest and it's pulling me towards my substance or my eating disorder behaviors or whatever other compulsive behaviors. So it's this, I might be getting pulled towards it. And the whole time I'm thinking, stop doing that. You don't want to do that. You should call somebody. And then we find ourselves engaging in the behavior of the substance anyway. And then that preoccupation where we're ruminating about it, we're thinking about it. Sometimes our pulse might be racing and we're pacing and we're just thinking about the next fix or the next time we're going to be able to use our behavior. Very similar in that regard. The neurobiology is incredibly similar with both of these in terms of our brain circuitry in the limbic system in particular. Eating disorders as well as substance use disorders get tied into our survival sense of the brain. And that's what it's almost like we're on autopilot to some extent, where we mean it from the bottom of the heart that we want to stop engaging or stop using. And then we find ourselves at the bar ordering something. And it's because our limbic system thinks that we need that thing for survival, that we're not going to draw another breath unless we get that beer or we engage in that eating disorder behavior. And so we find ourselves engaging in it, even though our spouse told us they're going to leave us and our kids told us they're never going to talk to us again. And we can interrupt that, as we know, because we've seen lots of people get into recovery. And do so very successfully. But really, we do need to interrupt that. And the best way is to really untangle it from the limbic system by getting time away from the behaviors and the substances. And of course, the reward pathways, we see that as well, that learning with dopamine that occurs. Dopamine tells us that something is enjoyable and pleasurable. And so when we engage in the substance or we engage in the eating disorder behavior, dopamine says, oh, I really like that. And glutamate, which we don't talk enough about, I don't think, commits it to memory for us and says, all right, cool, I'll remember. And then when we're dysregulated or we're angry or we're stressed out or we're having flashbacks, all our brain wants to do is regulate. And so dopamine says, you know that thing I really like? I need it right now. And glutamate says, go get it. That's a craving or an urge. It's a neurochemical cascade happening in the brain. It's supposed to happen in the brain. But I work with so many patients who will sit in group and they'll say, I feel so ashamed that I'm having cravings for my substance today or urges for my eating disorder behavior. And helping them understand that it's not because they're not doing recovery right. It's not because they don't care enough. It's this neurochemical cascade that's happening in their brain allows many of them to step back and say, I know what's going on in my brain right now. I know what you're trying to do to me. Bad dog, sit. And then we can call somebody and tell them we're having a craving or an urge. So those things are all very similar as well. And I have found that explaining the neurobiology as we understand it to our patients has reduced so much shame for them. And I help them understand that we are still responsible for the consequences of our actions, of course, doesn't erase those, but it certainly helps them understand it's not that I'm doing this incorrectly. It's not that I don't care. It's not that I don't love folks.
So for someone who's avoiding eating food, you say there's a chemical process in the brain that rewards them for doing that.
Yes.
Okay.
Yeah.
So it's like the opposite of a substance. It's like avoiding a substance.
Yes.
Triggers that same thing.
Absolutely. So the question, in case you can't hear, is for those folks who avoid eating food, there can be a dopamine rush initially. Much like a substance, we can get to the point where we're not really getting much dopamine, but we're just maintaining, and it's no fun for us anymore, and we've almost become kind of a slave to it. It can be the same thing with restricting with food, but initially, some of that rush comes from a feeling of power and control. That we get from, well, see, I'm superior to you because I cannot eat that cake. And therefore I have greater willpower than you. So we see a little bit of that rush come from that. And eventually that kind of goes away because again, we become kind of a slave to it. It's just a thing I must do now. Yeah, it's a great question. And for those of us who enjoy food, it's really hard for us to wrap our brains around somebody who is absolutely restricting. Absolutely, it's a great question. Both disorders involve disruption in appetite and satiation. There's obsessive compulsive behaviors, sometimes a full-blown diagnosis, sometimes not. A lot of self-destructive behavior and certainly severe medical consequences. But we've got more. We've got more similarities. Don't worry. So both of them involve a progression, which is this loss of control. And I typically describe it to our patients. By the way, we say patients, and this may be clients for you. A loss of control, I describe it as where we start behaving in ways that don't line up with who we are, that maybe are outside of our value system. That's what I consider loss of control. So I mentioned the dishonesty thing. My value might be honesty. And feeling like all that shame, that intense shame, because I'm not being honest with the people that I love and care about or respect. And so I'm starting to, we might even look at ourselves and say, who is that person? I don't know who that was that just did that. That's a bit of that loss of control. Both can be resistant to treatment because there's a lot of denial. And because, you know, both substances, especially the more social substances, right? And eating disorder behaviors are touted in this society. You're expected to go out drinking with your buddies. That's the normal thing to do for our people in college. Eating disorder behaviors, I mean, they're all over the place, and it's a multi-billion-dollar industry. So that can really contribute to that resistance to treatment. Continuing to use despite negative consequences, the approach that I take with our folks is I'm looking for consequences with a lowercase c. They don't have to be the ones with an uppercase C. I have a lot of people who used to come in and say, well, I've never gotten a DUI. And I'd say, well, how many have you earned? And they'll say, thousands. I drive drunk all the time. I'm like, okay. Well, my favorite was telling them, well, come back when you get one. I'll talk to you then. And their jaw would hit the floor. And, you know, it's luck. That's not no consequences. You just happen to not get any. So it's the same thing. I encourage our folks with eating disorders to kind of step back and recognize that even minimal use of substances can be creating problems for them. They are both progressive illnesses, and so we need increased amounts of the substance or behavior in order to achieve the same results, so tolerance, and then frequent recurrence of use. It happens all the time. And some of you may remember used to be if somebody was not staying sober in treatment, we'd kick them out and say, come back when you're ready. We have now learned that, I mean, ethically, sometimes we need to move people along, but that we can use that as data collection. We can say, all right, where are some of the holes in your recovery? What do we need to do differently this time? What could you have done differently last night? You know, those kinds of things. And then the risk factors are very similar, right? So we look for family history, including the culture within our family, within our neighborhood, within our faith, within our region of the United States, whatever it might be. What are their views on substances? What are their views on food? What are their views on spending? We want to take a look at that and encourage our folks to start to question some of that a little bit. Like, I've always just assumed that this is how things are, and maybe it's not servicing me any longer. The genetics, we take a look at the genetic history is a big piece of it, though I tell people you don't have to have the genetics there. If you give it the old college try, we can certainly cross, sometimes literally, we can cross that line into struggling with either of these. A history of trauma, I think we're starting to really understand that trauma underlies so much of what we work with. And then a lack of social supports. And so really helping people identify those social supports in their community. Okay, we can move on to differences. And I literally have 3 bullet points. That's it. So substances have a tolerance, right? That we are aware of. That's true for prescription medications that don't have any intoxicating qualities as well. We see a physical dependence with substances and withdrawal that is not applicable to eating disorders, but one of the things that I will say is if I'm working with somebody who started their eating disorder behaviors at age 12 and they're still engaging them at age 26, what they were doing at 12 is not going to do it for them anymore. It needs to be bigger. It needs to be more frequent. It needs to be varied and different and new. And so I would call that tolerance, quite honestly, because we're needing more of the behavior to get the same result. And then, of course, the goal for substance use treatment, even when we're doing some harm reduction, ultimately we recognize that abstinence may be the goal for somebody, whereas that is not what we want by any means with folks in eating disorder treatment. And we really want to normalize eating behaviors and start to work towards balance. And those are our differences. So really getting into the current treatment approaches, there's sequential treatment, which is what we've done for so long, where we focus on the most acute disorder first, and then we move on to the next, and then we move on to the next. And that has not been found to be the most helpful. And it's sometimes still necessary, right? Somebody may come in to eating disorder treatment and need to be medical detoxification from alcohol before we can do anything with them, or vice versa. We may need to see somebody get medically stable with their eating disorder first. So we do need to focus sometimes on the most acute disorder first, and typically that's going to be medical necessity. But what we see is treatment is delivered by different people in different locations, and things can fall through the cracks. The same thing with our parallel treatment. So we're working on all of the disorders at the same time, but with different providers, often in different locations. And again, patients are very savvy, and they know how to split us, and they know how to play us against each other. Even when we have releases and we communicate, sometimes we might have different approaches, and then we start stepping on each other's toes as clinicians, and that can become problematic as well. And sometimes this is the best we've got. And I've seen a lot of, when we start to create connections in the community with other treatment facilities, we can work really well with them. Absolutely. And, you know, we're moving towards some evidence-based integrated treatment. And that's really what we're doing at ERC and Pathlight, is we're trying to integrate it as much as possible. So we're treating co-occurring substance use, even though it's not primary for us, and the eating disorders and mood and anxiety disorders at the same time. And so what this allows us to do is communicate with each other. I can step out of my office and knock on either side of me. I have a psychiatrist, and I can talk to them directly. There doesn't have to be this email back and forth. It doesn't have to be waiting for, you know, someone to call me back from that office. And in this way, we can really connect with each other, not allow for splitting, and make the best decisions for our patients. So we do comprehensive screenings for both eating disorders as well as substance use disorders. How are we doing on time, by the way?
You're good.
You are good.
Okay. Am I going too fast?
No.
Okay. All right. So we're comprehensively screening for both. We are taking a look at co-occurring psychiatric disorders, any medical conditions that need to be addressed or managed, ordering lab tests with regularity, and then, you know, as needed, comprehensive drug testing. All of our folks on admission get screened. So we catch a lot of folks who say they've never touched a substance in their life, and suddenly there's like 6 things on their screen. And then really understanding all of these things independently and how they interact with each other in a combined way. And the medical complications, it's crucial that we have an understanding of these, you know, following our guidelines from the APA and ASAM, et cetera. The treatment plan needing to encompass all of the co-occurring psychiatric disorders, as well as the eating disorder and the substance use disorder and whatever else there might be, even if we're only addressing it in a very small way. Still want to make sure that that's on the treatment plan. And here we're going to move over to Jennifer. She's going to talk a little bit about the levels of care.
Hello. Okay. Higher levels of care, that's where we spend our lives, which is why we typically use the word patient, because it's a medical model. And as Leah mentioned, when someone, especially with the co-occurring, is really struggling, right? If you know someone or you're working with someone and it really is starting to impact their life, having them call a treatment center for an assessment never hurts, right? An assessment doesn't cost any money, and it will help someone really assess the whole picture. And if they do need more than outpatient treatment, they will assess like what level of care do they need. And so for treatment, this is for substance, eating disorders, mood and anxiety, or if they have all of them, unfortunately, combined. It starts with the most intense, which is inpatient, 24 hours, 7 days a week, and inpatient is very typically medically focused. That's going to be the detoxing. That's going to be if an eating disorder, the labs are off, if they need fluids, things like that. And inpatient for most people tends to be a shorter stay, followed by residential. Residential is where people are typically there anywhere from 45 to 90 days. I know with our company, each treatment plan is very individually made, so it does vary pretty widely depending on what the person needs. In residential, they're going to be working closely with the whole treatment team, psychiatrist, general medical doctor, dietitian, therapist, on what are their goals, what do they need, and starting to get in depth with how to cope with their distress, especially when they're pushing back against the eating disorder, and also a little bit starting to work on like what is that underlying. Partial hospital program, or PHP, is all day, 5 to 7 days a week, but the person goes home at night. Intensive outpatient, or IOP, is typically 3 days a week for 3 hours. They typically are returning back to work at this point. And then there's the outpatient, which is once, maybe twice a week. And a person who needs higher level support, especially when they start in the residentials and PHPs, it's really important whenever we can to step them down to the different levels, because it increases the challenge and it gives you a good idea where the patient's able to really fight back and push back against that eating disorder, substance disorder. It can be, some people unfortunately have to go from residential straight to outpatient, depends on what area they live in. And I really strongly encourage, whenever possible, try to do that slow step down. And with that piece, we get in a little bit towards like some of the treatment models, and I do aim this at, hopefully everyone can take 1 or 2 things away with them. Anyone here ever heard of DBT, dialectical behavior therapy? DBT is for me. Okay, Marsha Linehan, I worked with adolescents a very long time. So Marsha Linehan created this actually for those who are borderline personality disorder, chronically suicidal, self-harm, and it's been effective in treating a lot of the different eating disorders and helping them cope and manage as well. So real quickly, DBT talks a lot about these different mind states, right? They talk about an emotional mind state where the decisions are being made based off emotions, right? I'm trying to think, a good example of a decision made off of emotion would be if I'm trying to think, what do I really want? I really want that cappuccino. I am obsessed with peppermint cappuccinos, which if I drink too much would be a behavior. I am obsessed with peppermint cappuccinos, and I will die. I have to get the peppermint cappuccino. Nothing's going to stop me from getting the peppermint cappuccino, even though the dang Caribou was only drive-through only. I went back and got my car to get the peppermint cappuccino, right? And then typically emotion mind's a sign. If Leah went, hey, Jen, think you might be a little bit emotion mind about the peppermint cappuccino. And I'd be like, I am not emotion mind. I'm a completely rational mind. And you can just kind of tell because they're so fixated on whatever that is, or even the emotion they're struggling with. Rational mind is that reasonable logistical mind, right? That's that mathematic, analytical, very fact-only mindset. And in DBT, they talk about living the balance of your life in wise-minded state. Wise-minded is a mix of emotion and reasonable, right? Because guess what? There's going to be times we're going to want to be full emotional mind, right? I'm celebrating a friend who just got married Sunday, right? I want to be an emotional mind about that. And there's going to be times we're going to want to be in full rational mind. I am doing the budget. I don't want to be an emotional mind when I'm doing my budget. And wise mind balances the both. It's acknowledging that emotion and putting in the factual piece. And I show that because when it comes to eating disorders, hold on, I always skip this slide. So a lot of times when people start treatment, a large majority of people in treatment who are struggling with eating disorders and substance disorders have very large emotion mind and a very small rational mind. Now, they can reverse, it doesn't impact everyone, but what happens is because the emotions are making all the decisions, they struggle to access that problem-solving rational mind. And what we do in treatment is we build layers around the rational mind. We build layers of having the support of the treatment team. Caregivers, loved ones are also just so important. What is their support outside? We teach them the different DBT skills. And soon enough, that rational mind starts looking like this, the balance of the two. And so I like to conceptualize eating disorders to look like that big emotion mind, and the person is kind of lost in that eating disorder. A lot of eating disorder approaches separate the eating disorder from the person. And so sometimes I just naturally oxidate it. They separate that. Someone needs to mute. Okay.
Help me.
Thank you, Mark. All right. So, and basically with the eating disorder is We separate it because oftentimes when someone starts struggling with an eating disorder, and I think you see this with substances as well, it's not really that person you know when it's really full blown. They're kind of a little bit lost, right? And so what we do is really work on that person and their caregivers to separate the eating disorder from the person. Some people even name their eating disorder. This is really well illustrated. There's a book called Life Without Ed by Jenny Schaefer, and it is on Amazon. And Jenny has done a brilliant job at showing that separation. And that book is great for anyone who wants to understand the eating disorder brain, and also even patients. That's a really helpful book. And so what we really do is separate that person and start rebuilding that person as well through treatment, that they can start getting their values back, living their life according to their values, and pushing against that eating disorder more and more. So with DBT, especially with treatment, and especially if someone needs more supportive treatment or acknowledging, one thing that I have talked to outside providers that's helpful is using the DBT. Depending on what manual you're using, it's either 4 options or 5 options when in distress. The new one has 5 options. It hasn't caught on, but I had to use the 5. And DBT people, hey, do you know the 4 options or 5 options when in distress? Okay, love this. Apply it to my own life all the time. So especially when someone's struggling with an eating disorder and you're working on a problem now, acknowledging, like, I think there's some eating things going on and you might need an assessment. And typically when someone needs an assessment somewhere, the answer is, no, I'm good, I'm fine, I got this, I will stop. They truly mean that when they say that. They're not lying. But what happens is, remember that big little eating disorder? The person struggling to fight against that, a lot of times they really do not have it, even though they really mean it and think they do. So the 5 options of distress, and you can kind of move these either in order or kind of throughout, include problem solving, which is doing whatever you can with the person or the person themselves, problem solving the situation, changing your interpretation. Perhaps like in that situation, the person struggling, their interpretation may be not the most effective. What are other people's thoughts or opinions? If they're feeling like, you know what, my cappuccino addiction really is not a problem, Leah, it's okay, right? And a change in interpretation would be going, okay, Leah, what do you think of me drinking 20 peppermint cappuccinos a day? And me then going to maybe my doctor or another loved one and asking the same question and really practicing hearing what are they saying and seeing if I can change my interpretation from it's not a problem to, okay, I'll cut it down to 1 or 2 if I can. Do nothing, stay just as miserable. When someone's in a bad place, whether depression, anxiety, or substance, this is an option. And a lot of times there's a lot of shame with that. And even though, like, when you see someone you love or are working with suffering, you want to do the other things and get them better, acknowledging that that's an option they can choose actually is really empowering and actually helps get them out of it a little bit easier. Radical acceptance. In DBT, radical acceptance is not liking or agreeing with the situation and choosing not to suffer over it by radically accepting it over and over again, that they can move on from it. In the new manual, they have making it worse, which some problems you definitely can make it worse by increasing my cappuccino consumption to 35 a day. So an example of utilizing this is at one of our old locations, there was a reserve behind it. And in the fall, we would get spiders, and I am really arachnophobic, like really bad. And they were big and hairy, and no matter how much cleaning and exterminators came in, they would still come. And I was leading a process group with the adolescents, and this big hairy spider comes running through the room. I'm losing it. I go and get my emergency can of Raid. I keep locked up in my office, and I'm sitting there and we cannot find it. So I'm thinking, like, we're moving this process group to a different group room. And then the adolescent patients are like, don't we do exposures? Yes. Isn't this your exposure? Oh no, they listened to me. And I'm like, yes, it is. And they chose, only one other person did not want to leave the room to stay in the room with the spider for Jennifer's exposure. And I'm like, well, a big thing as a clinician when you do exposure work is you have to be willing as well to do it, especially in the old school OCD model. So They named the spider Cinnamon, and what I then did was literally go through the options in distress. I did share this with them the next day and with their parents and multifamily group. First, I problem solved it. I sat in the chair on the opposite end of the room with my canner right next to me. The girl also afraid of spiders. It was in between us. And I did sit at the edge of my chair and decided, okay, this is what we're gonna do. Cinnamon, it's gonna be really hard for him, hopefully, to get to me without me knowing it and running out of the room screaming. I may have actually asked one of the psychiatrists at the time to come and look for him as well. Changing interpretation in this moment. I am thinking, this is completely emotion-minded, by the way. I am thinking, this spider is going to come and eat me, kill me, and bring his friends, right? That's my initial thought. That's a good example of what people say when they think they're in rational mind, but really emotion mind. And you're looking at them going, that's not rational mind or wise mind. And the interpretation is really quickly, I realized what a learning experience for these patients to see me both in a little bit of distress, work through it, apply the very things I teach them, and have an effective process group. And we were able to do it. I could have done nothing and stayed just as miserable and been really not present in that group and ruminate over and over again about Cinnamon the spider. And I'm not gonna say my brain didn't go there, but I was able to get it back on task pretty quickly. Finally, radical acceptance that there's nothing I could do about Cinnamon in that moment. And I could choose, I could be in suffering in that rumination, and this whole thing called I have suffering DBT, that's really fun. And I'm gonna choose to radically accept that even though I don't like or agree that Cinnamon is somewhere in this room, I'm gonna choose to move on and have an effective process group. Finally, there's making it worse, which would be me yelling and screaming out of the building, probably cursing and losing my job. But 5 options when distressed is someone's really struggling with treatment of any kind, or really just that move a change is a really helpful tool. You can Google it, it will come up to work through with someone or even your own self when there's life problems. Okay. Emotion-focused family therapy is the next takeaway tool. Emotion-focused family therapy, you should know, is I was that person in grad school that was like, I hate family therapy. I'm never gonna do family therapy. That's not needed, which is funny because I wanted to treat adolescents. I don't know why the teachers weren't like, hey, Jennifer, they go hand in hand. And I have to tell you, especially working at higher levels of care, and I really think anyone is supporting patients or clients, it is very helpful. It's by Dr. Adele LaFrance. She has an amazing website, and we were fortunate enough that she came and did a few trainings with us 4 or 5 years ago, I think it was now. And even though it says family therapy, it really is more like parent or caregiver coaching. And I use both because even adult patients, we think family therapy is so crucial. Whoever the person identified support person is in your life should be working with you to learn how to support you in an effective way. Now, support can look like many things, right? People think when they think support of someone in treatment is like almost turning into a therapist. No, it's not that at all. It's learning how to identify, acknowledge, and validate the emotions, and kind of pushing like a little dolphin does its baby, kind of nudging them along from time to time, which is really important. And I love cartoons, so I always have to have at least 1 or 2 in each slide. And part of the reason I love EFFT and really believe in it is its core beliefs. And EFFT believes patients want their caregivers to help them heal. And it's really important, like they're almost these disorders push against their parents, push against their loved ones in their life to get them to go away, right? And even though that might be what they're saying or feeling, they typically do want, no matter what, especially when with moms and dads, that's your parent. No matter what happens, there's going to always be that piece of you that loves them. Granted, EFFT, of course, is not indicated if there is abuse in certain other situations, but as a general rule, even if a parent has an eating disorder or substance use, even if it's the eating disorder is active, we still believe they can help support their loved ones. The next one is caregivers want to support their loved ones and help heal. Even though we can get frustrated with loved ones in their life of like, why are you maybe enabling, right? Why did you, Leah, give me that Starbucks gift card after we had that conversation, right? But realistically, Leah's probably frozen and afraid if she moves wrong, it's gonna get worse. And at least where we're at right now, she knows. they're gonna be worried about the coffee drinking after this. Thank God I don't have the Starbucks. But really, caregivers typically really do, even with the frustration, want to help their loved ones heal. Caregivers can overcome fears that may help keep them paralyzed, especially when someone comes to treatment. We are not seeing that family in their best moments. We're seeing them in their worst, and paralyzed is often something we see. Every action has a reaction, and loved ones need to be coached. And we talk a lot about self-efficacy in EFFT, and we typically see when people come into treatment, very low self-efficacy, right? We see a lot of caregiver fear and self-blame, right? A lot of low empowerment. Has anyone ever had someone come to them or come into treatment or their office or just someone they even know, and it's like, the person's like, okay, fix her, fix Jennifer. Like, just, I can't. And it's so easy to judge, right? I think everyone who's like worked with clients or patients, or if it's like someone even like in a church setting, wherever you all work, has probably maybe had that experience, and you kind of have a judgment of like, well, no, I'm not going to fix them. Like, this is you too. But in EFFT, we really practice on taking that, reframing that, because the reason that person, once again, is pushing off and doing that is because they're afraid, they're scared, they're not sure what to do next. And when you have low self-efficacy, you're more likely to have problematic behaviors, right? So even though I have told Leah I am not doing any Starbucks anymore in my peppermint cappuccinos. By the way, all the Starbucks are out of peppermint, which is really upsetting. But she may still, even though I sneak one in, she may notice my cup is there, but not say anything, right? Which we can judge very easily, but really have to look at what's going on there once again. So what we do in EFFT is take that caregiver self-efficacy and we slowly build it up. We take that fear and self-blame, and it works with something called the animal models, which was originally by Dr. Janet Treasure. And it even takes like, what kind of caregiver animal are you? What kind of emotion animal are you? And take some of these things of how people react and put into animal models. And it sounds, as you say, like kind of corny at first and a little bit almost like childish. And I've really only had 1 or 2 families ever be like, no, this is stupid, I'm not doing it. And what it does is teach them that, like, if you're one of these extreme models, how can we get you to the middle? Because the goal is to have people really move to that middle action. I don't have time to get, that's a whole 20-minute thing, so I do not have the animal care models in here. But if you're interested, Dr. Janet Treasure, look up animal care models. It's definitely online. So we take that fear and self-blame and we work on that empowerment that they are able to do this and support their loved ones emotionally and coach, right? That doesn't mean taking accountability for their emotions, it's coaching them. And that leads to symptom interruption and emotional support. It teaches the caregiver that when Leah sees that Starbucks cup there, of going, Jen, what's going on? You know, is there something going on today that we see the Starbucks? And the answer is I had to present on a Friday afternoon and needed it. All right. This is one of 2 really strong points with EFFT I hope you can take with you. And this is something, once again, we can apply in many areas of our life, and that's remembering the power of 1 degree. And what EFFT says is if there's a flight going from LA to New York and it is 1 degree off, will it land at New York at the end? Anyone know? I didn't know the answer either. And if you think about it, if it's off that 1 degree, it's going to start heading north to Canada or down south to Florida. It's not going to land there. And because that 1 degree of change has a strong impact, even though it may seem very small. And with that 1 degree of change of even that 1 prompt and consistently doing that 1 prompt is going to change that trajectory of treatment for that person a little bit. It doesn't mean you have to do every single thing right. It's just that 1 little adjustment, that 1 little pivot that really can change for a person. And really kind of thinking when working with someone of like, explaining that to them and going like, what do we think the 1 degree can be that we can work on right now? That 1 little goal, and empowering them over time really does make that difference. Another thing that this is actually both DBT and EFFT really hate the word but, right? Because when we go to someone and Leah goes, Jennifer, I really know you want that cappuccino, but I stopped listening. Like, right. She's gone, right? And with EFFT, they teach, instead of but, saying the word because. And because is really powerful in this statement and practicing this for many different levels. And what they do in the because statement is, I understand why you feel a certain emotion. You list then 3 reasons with because in it, why they feel that emotion that you have observed, right? I understand, I'm trying to think, the best example I have is when I first was getting trained on this, I forgot to do my homework, and I'm a rule follower, and I was on the L train in Chicago with my husband, who really hates it when I do my therapy homework on him. And we're on the very crowded Chicago L train, clearly before COVID. And I'm going to him like, I understand why you're angry at me, because I'm practicing my therapy homework again, because there's people looking at us, because you asked me not to do this. And it's funny that even though that was a therapy homework thing, he was like, well, yeah, like that's why. And he's usually super mellow, but he really hates it when I do that. And so when you understand the emotion and not just acknowledge that emotion to them, but why, it really shows you're listening and observing. And when there's anger, you validate anger first. Anger gets a bad rap in our world that we're never allowed to be angry. It's not about not being angry, it's keeping anger and learning how to express it in moderation throughout, and also validating it when it happens. Doesn't mean if anger is leading to throwing things or punching walls, never okay. And once again, that's just the emotion I think we shy away most from, because anger pushes people away from us, where a lot of the other emotions naturally bring us closer. Matching tone and volume is crucial for effectiveness here, which was really, at first, I judged it because I was like, I'm the calm therapist. I always remain calm, de-escalating people. Actually is really helpful that the caregiver matched that tone. And I had a family whose kiddo was in and out of these higher levels of care, inpatient, residential, PHP for over a year. And the child was so sick, the eating disorder was so sick, that every time there was a meal, the escalation was insane. It was impacting the whole family. Police were called to the house numerous times a week. It was that bad. And we're getting ready to step the patient up again, and I'm working so hard not to. And I had learned this theory probably like a month or so before, and been telling them about it. And I finally went to the parents like, okay, we're firefighting every session. We're not getting anywhere. First 30 minutes, let me teach you this EFFT, and then we'll go into firefighting. And they were committed, so anytime they went to firefighting, I could very firmly redirect them. And I taught them this, and the mom's like, I don't know, you want me to yell at her? Like, you're gonna call like DCFS or something on me? And I'm like, yes, like not inappropriately, but do the statement of what you're observing. And the mom came in, and it did take a few weeks. It wasn't like a one and done. And she went like, it worked. And we talk a lot about 1 to 10 scales in EFFT and DBT and emotions. And what it did is daughter started to escalate and was screaming at the table, was probably at an 8 or 9. And mom went, I understand why you're angry, because you can't be in gymnastics because you've been in treatment for a year because you've lost all your friends. And thing just said playing music. I'm glad you think I'm singing some stuff. That was cute. Okay, and basically the daughter went after the mom, and the mom matched the tone, like, yeah, right? And stopped. And what happened is they got through that meal. Now, was daughter still very escalated? Absolutely. But she was at that 8, 9 and got down to a 5, 6. And one thing, especially going back to DBT and the emotions, is when someone's feeling emotions like 4 through 6, sometimes 7, if that 1 to 10 scale and 10 is the highest emotion, that's actually good to feel in and experience. And that was enough for daughter to be able to get through the meal. The police were not called that night, and actually were not called again for the rest of treatment. Then they went skipping off into the sunset. Like, no, they still had a lot of struggles. They had a long way to go. But that was like their example of their 1 degree. That change is what shifted that little bit in that family, when mom could stop, and dad, and acknowledge that emotion first. And once again, it didn't make it easy, even a little, but it was enough to change that trajectory for sure for them. All right, finally, the tree. So this is the EFFT tree.
That's what I'm saying.
Holy
I
cow.
want to validate that.
You want to validate my motion? Can you do because? So the EFF theory this is something that is amazing to have laminated in an office. And what it does is you work with the caregiver first within themselves, going, okay, sit down. So what things do you notice up above in the leaves? Do you notice that you might, have any of these actions or showing these behaviors, with Leah who might be struggling? And they kind of go, yeah, like I accommodate, there's some denial, definitely get defensive, definitely, I feel like projection definitely should be up there. And you identify with them that and why. And what we do then is dig into the roots, dig into what we can't see. And what do you think might be going on underneath that's leading to these behaviors that we all see within the caregiver, right? And almost always there's that self-blame, that shame really comes up. And so what we do is have a conversation around that and why that's working, why that is, and that effectiveness. And then you go, okay, so your loved one, what are you noticing within them? You do the same. You can also do it with the patients as well. And it's just a very helpful tool that when you start noticing those things, working with them and recognizing that, and then being able to get to the why, like what's going on underneath, and really being able to work with that as well. And that's another thing that I've noticed is really helpful, for that 1 degree of change as well within the families. All right. And I went real fast. So
I'd like to give an example.
I was like, I know you have a
actually
bunch
working.
else that we,
I had a patient several weeks ago, actually. Mom was over the phone. Mom was asking them about their trauma, and they'd never talked about their trauma with mom, mostly because a lot of their trauma was because of mom. And they said they finally decided to get honest, and they told her, honestly, Mom, the reason I haven't talked about it is that you contributed a lot to it. And Mom started saying, well, you were always too sensitive as a child, and other kids wouldn't have handled it that way, and never denied. And I actually pointed that out to the patient. I'm like, interesting that she never denied that she was contributing to your trauma. But what I did, so patient was frustrated, feeling disheartened, feeling, hurt. And I said, yeah, that sounds really frustrating to finally share and be so vulnerable with mom and to just kind of get cut off at the knees. What do you think mom was feeling internally? And the patient paused for a second and they said, probably ashamed. And so really helping them understand, because I think a lot of times our caregivers, their behaviors speak to something else and they get interpreted in a particular way, and really helping people get behind that and understand what's really driving that particular behavior or that response helps create a little bit of empathy. And saying, well, yeah, no wonder she probably feels ashamed. I just told her she caused my trauma. And really being able to recognize that. And the patient said to me at the end of the group, they're like, that was a huge light bulb moment for me to really think about how she might have been interpreting what I said to her. So I think that this can be really helpful. And I didn't talk about the tree, but really what's behind, what's underneath it, what's the root of it? Because our behaviors say a lot, but they also hide a lot. And so really being able to do a little detective work can be helpful. I don't have anything else to add to that, but yeah.
Sounds good.
I'm trying to think if there are any other, I did want to say something about not using but.
Yeah.
And we talked about the because. There's also, and our patients start to catch on and they chuckle every time we say the word and. Because we'll say, oh, I can see how you're feeling that. And we do this big dramatic and they always know that the next thing is coming. The intention behind replacing the word but with and is to show that two things can be true in the same moment, even if they feel like they're opposing ideas. And so it can help people recognize that it doesn't have to be completely black and white. And there's some of this gray area in between that we can live in that can be very, very uncomfortable for some folks. And part of what we do is to try to get them comfortable with being in that gray area. Not everything is gray, obviously, but sometimes we have to recognize, wow, that was really invalidating what mom said to you, and X, Y, and Z. And they're always like, oh, a dialectic, they don't like it. So that's another, I like to point out that we can do the because when we're kind of doing, especially with, I think, adolescents and families, but just in our therapy with our patients or just our discussions with our clients or our members or whatever it might be, using that and to kind of soften it a little bit because they can get the blinders on. So that would be all I have to add.
Yeah, I feel like DBT and EFFT should have just taught to the world. Imagine if we could all believe we can have two truths
Yes.
in many
Yes,
situations.
yes.
So.
Mm-hmm.
All
Yeah.
right. So what questions do you all have? We have a couple minutes left. Yes.
This goes back to the very beginning of your presentation.
Yeah.
You talked about one of the symptoms of eating disorder being rigid thinking around food and bad good foods and all that kind of stuff. And I know in 12-step recovery programs with eating, a lot of times they talk about trigger foods and they talk about food plans. How do you reconcile that, the two, or can they be reconciled?
That's a tough one. Yeah. So the question is that kind of some of those eating disorder patterns where we have really rigid feeling or thinking about foods or we're judging them as good or bad. And then in some 12-step programs, kind of having food plans and having like equating foods with, it might be triggering or et cetera. I do think that we can work with that. One of the things that I talk to my folks who are choosing to go to 12-step is that, those folks, they're not your doctors, they're not your attorneys, they're not your nutritionists. And so our folks who do work with eating disorders, really trying to find someone within that community who maybe also understands eating disorders, maybe has had their own treatment. And there are lots of people in Alcoholics Anonymous meetings who have had treatment for eating disorders. And so really interviewing their potential sponsors, et cetera, take what you need and leave the rest. I really try to empower them with that. But also I think, we have to recognize that there may be realistically a triggering food for somebody who's in eating disorder treatment that might activate some substance use. And so I think we just really have to individualize that treatment plan, help really work with them on understanding that this is not to be a blanket kind of approach, but this is this one specific food we've identified. Maybe down the road, we end up doing some work around it with some exposures. I don't know. I think it would really depend on what we're talking about. I don't know if that's helpful, but that's the way I would approach it. Yeah. Other questions?
Also,
We've got
sorry
some-
for the ones online that said the slides were not changing.
Oh,
I'm trying to
no.
see if I can get it. It's definitely sharing. Oh, it's showing my cloud is. I do not know why that is. But I'm going to try
sorry,
to.
we didn't see that.
I'm going to try to continue to share them and go through them so you can see them.
Yeah.
Can you see them now? That's so
Okay.
weird. I'm
Yeah,
so sorry.
that's-
I've never had that happen before.
Yeah.
Okay, so I'll slowly kind of go through them now as well. So hopefully that will help you a bit. Okay, as we continue to answer questions. Sorry. Okay, are they moving now?
No. Oh my goodness.
Yeah, I don't know. It has this little angry cloud.
Oh,
Oh, I'm so sorry. It's recording though.
okay.
Okay, I'm terribly sorry
So
about
we'll
that.
have to try to figure something out so that you can
You
get,
the
yeah, you can get the
We'll
information.
talk to Terry.
Yeah, I do apologize for that. Maybe Mark, you can make a list of those folks who are virtual and we'll see if we can do, oh, why does it say participants can now see your application? Are they changing now? No,
No.
okay.
Okay. there's
Not sure
something
what
else.
that's about.
Yeah.
Yeah,
Let's go to
not
the
changing.
chat. Okay.
So, yeah,
All right. I
if
so
there was a link
apologize.
to it, yeah, there might be better to do a link to it.
Okay.
Okay.
If that's possible, because I don't think I have a way of knowing who's in.
Okay.
Okay.
We'll figure out something.
Yeah. All right.
Yep.
Yeah. I'm so sorry about that. Well, go ahead and type in any questions you might have based on what you can remember. Any other questions from the folks in the room? Let's see if any come up.
One question about a symptom of the eating disorder. You talked about the dental problems that can occur. Is there something about dry mouth or like I
Yeah.
feel like at times I've picked up what just sounded like speech
Mm.
changes and I was really suspicious.
So I'm so sorry. I didn't
No,
mean to-
just, I was suspicious of an eating disorder
Yeah.
because there were some other things going on and then I was like, oh, and also, like it's not sounded like they had just had a pierced tongue. And I knew they hadn't.
Okay.
But they were like, oh, but like this.
Okay.
And I just started going, wait a minute.
Yeah. So maybe wondering if a physical symptom of eating disorders might also be some dry mouth that could impact like clear speech, that kind of thing.
I haven't heard dry mouth specifically, but that I'm also not a medical doctor.
Right.
But I definitely could see that happening, or swelling, because swelling definitely can happen to of the glands. Someone with purging bulimia, you sometimes notice gets very swollen around the face and glands. So I know the swelling definitely could be a piece. So yeah, the talking between that and the enamel breaking down could,
I would
onto
also
something.
guess that, we have a lot of folks who limit their fluid intake as well, and so get dehydrated. So that's and then we have folks who fluid load too. But so that I would agree that that's probably something that could happen. One of the things that was helpful for me is this idea of, well, if we're not going to label foods as good or bad, how the heck do we talk about them? Like, I was like, oh, no, what do I do? And what my approach, I have an 8-year-old, and so I'm hyper aware now that I work in the eating disorders field. But one of the things that I try to approach it with is not talking about healthy foods or junk food, but which food is going to get me the most nutrients right now? So you had those potato chips, and so we need some stuff that also has nutrients. So really kind of normalizing that, like, of course you can eat those things, but our body still needs stuff that's not providing for us. So really thinking of it in terms of nutrition as opposed to good or bad or healthy or junk food is the way I've approached it, that I think has been helpful. Yep. But I don't,
The other thing I think might be helpful is, I know we presented this last week, similarly, and someone mentioned especially the exercise when they're working like a 12-step program. A lot of people do replace that with like walking or running and concerns. And I do know we talked a lot about how, as like a clinician, just checking in on that piece, right? And when they're doing it. And once again, it's going to be how long and how often are they doing it? If it's, you would know better the first few weeks or first few months of ceasing a substance, I think you would see a little bit more, but especially as they're able to work and cope with life, is that backing off, or is that turning into they're avoiding and missing things because of the exercise? So I think sometimes when people see presentations or working eating disorders, they go very extreme, like, what, you can't run marathons? No, that's fine for a healthy individual, but you also have to make sure you're getting that nutrients and your body's able to handle pain as well.
Yeah. I think, again, it's about frequency and intention and some of those things, and then pattern and, how long, or we talked about the hour and a half a day for more than 4 or 5 days a week, et cetera. And so really paying attention to that. And again, expecting it maybe initially and then hoping that it backs off. But we have to pay attention to those things and potentially get folks assessed, I would say. Yes, please.
Just wanted to say 2 things. One, thank you for noting that you really can't tell about someone having disordered eating if by looking at them.
Yeah.
I'm a meth addict in recovery, and everyone always assumed that I really didn't have a problem because I weighed 270. And then the second part of that is I really think this is so important to have this conversation about the connections between substance use disorders and eating disorders, because I remember myself, in my own experience, part of using meth is that you don't eat for things. And months, years after stopping using meth, I still have disordered eating. And clinicians will say to me, it's not the meth, it's my brain.
Yes.
Why am I having to teach them about it? But it's another matter.
And the body physically, when there has been that eating, especially for long periods of time, thank you for sharing, by the way, really appreciate that. And the body takes a long time and longer for others to be able to get back to that routine eating and be able to figure out even where that energy goes. It definitely does take a lot of work. And working with the dietitian on what does that look like for each person, because it's uncomfortable when they start
moving back to more normal.
So someone was just kind of thanking us for pointing out that you can't tell if somebody has an eating disorder based on their body type or the way they look, and how important it is to really, we think it's important too to talk about these two things as evidenced by this presentation. But yeah, I'm glad. And I think, you know, it's much like, I think about many of us, you know, when we get into recovery, we're so used to having been lying all the time that we're in recovery and it's like the knee jerk and we think, well, why did that lie just come out of my mouth? And it's because our brains have been rewired. And so we have to do a lot of work around nutrition and like getting our hunger cues back, especially if we've spent years using something that has suppressed those. So it really is a matter of changing those neural pathways again. And that can be really challenging, especially if the clinicians and folks that we're working with aren't getting it. That's pretty scary. Yeah. Thank you.
I will share one other kind of disturbing story, and especially since we're at a faith and addiction conference. I was with a dear friend. We were sitting at church. We were getting ready, and she's been through some stuff, and I was starting to suspect eating disorder. We were getting ready to process for the Eucharist. She had looked up on her phone how many calories were in the host.
Yeah. So that's interesting. So again, in case folks looking up how many calories are in the Eucharist, the host, I think, you know, that may be indicative of, like you suspected, some disordered eating. And, you know, that's part of what's happened in society. Like, it can be really helpful for some folks to see those calories, but for folks who struggle with disordered eating, it's hugely anxiety producing, and it can really help, like, we shut down then. And then that sounds like in that particular case might even interrupt her engagement in her faith.
Oh, it hugely did.
Yeah.
And she was even, and then she was honestly like disturbing my, right? Like that's a beautiful moment where I'm really kind of prayerful, and she's showing me things on her phone, and she was worried that the Catholic host has less calories than the Episcopal host, and I was just like,
well, that's true.
Well, we learned something new.
I know, right? I was like, oh my gosh, you know, it's the bread of heaven. Please just go.
So people start switching ministries because of the caloric intake of the hosts.
You know you have a problem.
Yes, exactly.
It's interesting because we do a lot with values, and having patients like lay out their values, getting down to the top 10 or 12. And so often it's interesting. We get a lot of independence and we get a lot of spirituality as well. And they're like, well, but this is giving me independence. And it's like, well, look at all your values and what ones are being impacted because of these behaviors and that struggle. And it's amazing how often we're like, okay, like that spirituality's been impacted, that family relationship's been impacted. Then they kind of go, oh, so even though like this, it seems like the eating disorder or chemical dependency disorder is actually a value. It's really not, because it's taking me away from my other important ones.
She's doing a little better. She did get it addressed.
Okay, I'm glad to hear that.
Some
it takes time.
And, and eating disorder recovery, it's a little controversial, recovered versus recovery. Most people do say recovery because we do a lot of relapse prevention, and relapses do happen. And we hope that with education, they don't collapse, right, where there's a fall. And if they do, that's okay. Let's move forward and let's not judge that. And so it definitely is not a straight line. It's when you look at eating disorder recovery, we always say like there's a line and it's like this big hairball mess in the beginning, or you kind of go up and down. And hopefully with each time, if it is a person who's struggling that needs numerous rounds of treatments, it gets a little bit better and easier, because you never unlearn what you learned in the beginning. And another piece is with both is the brain can be impacted in so many different ways from substances and eating disorders, all the eating disorders, that sometimes what is being run in groups, individual sessions, isn't always absorbed immediately. So very specifically, like at ERC, our curriculums are 8 to 12 weeks long. We repeat them purposely because as a person gets better, if they're still there, you never know what they might pick up on different in that group as their brain and body are healing.